Thank you. Yeah, this has kind of become a controversial topic of sorts. So we'll talk about that today. I'll go through the research I've been doing on EIPH and asthma. So we've done two separate studies. The studies were funded by Zomedica. So let's get into it. Just a little bit of a background on the use of Shockwave. At least the first known use that I'm aware of was by Dr. Martin Allen. He's a centerbred racetrack practitioner in Florida, and started doing shockwave therapy on those racehorses immediately after they would bleed after a run. And what he was seeing, at least this is anecdotal, was that there was either resolution or at least a decrease in EIPH with the shockwave therapy. And he was able to reduce or even in some cases stop using furosemide as a therapy. So they're getting reports of this. Zomedica talked to me about kind of getting some data together. I've been working a lot of barrel racing horses, and obviously that's a big issue in barrel racing. And so we started treating horses and just kind of saw what the results were. So we'll talk about that today. Just a little background on EIPH, and this may be a little basic for everybody listening, but I just kind of like to go back to the basics when I think about what we're treating. And so, when we think about EIPH, there's really two main mechanisms that create it. One is increased pressures, positive pressures pushing on the inside of the capillaries in the lungs. And the other one is elevated negative pressures pulling. And so when we have a decrease in the airways, so with airway obstruction, we have increased negative pressures, increased pull on the outside of those capillaries. That horse, when it's running, it's breathing in 4 gallons of air per minute. So that's really high pressures. At the same time, that heart's beating 4 times per second, pushing on the inside. So what can we do about that? Well, as far as decreasing airway obstruction, there's a couple of things that we can do that we know can be effective. So if we have any kind of nasal airway obstruction, sometimes the nasal strips, the flare strips can be effective. There's been quite a few studies on racetracks in Florida showing some improvement in race earnings using the flare strips. We can treat asthma. So asthma creates mucus in the trachea that can cause airway obstruction. It creates bronchoconstriction, mucus in the bronchioles. So all those things can impede airflow. So if the horse has asthma, we can treat the asthma, improve the flow of air through the airway. And also if horses have upper airway issues, left laryngeal hemiplegia, things like that can obstruct air, obviously we can correct those. As far as decreasing circulating blood volume, really there's not a whole lot of options there. It's furosemide or bloodletting. Obviously furosemide's the better of those two options, and generally considered the most effective treatment for EIPH. There's a kind of a third category that's not proven that I wondered at first if maybe that's what the Shockwave was doing on these cases, was improving systemic compliance. So that's basically just the excursion or on inspiration, the ability of the lungs, the pleura, the chest cavity, the diaphragm, all to expand maximally to allow maximal airflow and least impedance of air going through the lungs. And so that's just kind of a theory that maybe if we could somehow improve that, or if a horse was constricted in that way and we could make that better, then maybe we could help them as well. With shockwaves, are the lungs safe? I was told in my internship that it was not. And the reason for that is they were doing more focal shockwave on people and in children with some obstructions. I think they had done shockwave and it damaged the lungs in a child. So that was the reason for that. Now, a study was done at the University of Cordova. It was not published. In that study, they had 2 horses that were going to be euthanized anyway for issues not related to the lungs. And so they picked 2 spots on each horse and did just focal shockwave, 1,000 to anywhere from 1,000 to 3,000 shocks, depending on the location they used. And then those horses had gross pathology performed and also histopathology following euthanasia. There were no findings on gross pathology, and on histopath, there was just some mild hyperemia at the pleural surface. So really pretty minimal changes there. I've done probably around 150 treatments now total on horses and studies, plus just horses I treat in private practice. All those have been done with E8, so the highest energy setting, anywhere from 750 to 1,000 shocks per side, so left and right. We always treat both sides of the lungs. I've had no adverse events, no symptoms of lung trauma, nothing negative that we could attribute to the treatment. So what are we shocking when we're actually have that trode on the chest? Well, you've got ribs, you've got intercostal muscles. There's some veins, artery, and nerves there. There's some fascia. You also have the visceral and parietal pleura, as well as the lung parenchyma. We know that shock waves don't really travel through air very well. So majority of that energy gets dissipated or released at the pleural surface, at that air interface. I've been using the 80 millimeter trode. I think it probably doesn't matter the depth so much. You probably wouldn't want to use the 5, but I think if you use 20, 35, or 80, that probably doesn't matter. I like the 80 because it's got a larger aperture, and so I can just cover more. I can cover more lung surface with the shock, and I think it's just more efficient way to do the treatment. But I don't think the depth is so important because I don't think it really goes much past the lung surface. A little background on the bleeder study, on the EIPH study. We looked at barrel racing horses that had made runs in the prior 2 days. Those horses had to have exhibited epistaxis or at least symptoms of EIPH. We left the symptoms pretty broad initially. More towards the end of the study, we started requiring that those horses had epistaxis because we're just having so many screen fails for barrel races that thought their horse was bleeding and it wasn't. If the horses ran on Lasix, that was fine. They just had to continue at the same dose throughout the study. They couldn't increase the dose. And they couldn't start Lasix during the study and could not start any other medications during the study for Lasix or asthma or anything else. We had those horses just perform light work the first week. And then we wanted those horses to go back and do a run at a barrel race. So an all out run at a barrel race. And we had them come back immediately after for the follow-up. From a diagnostic standpoint, of course, we got clinical history, physical exam, all those things. Each horse had an endoscopy performed. We were screening for upper respiratory pathology. We wanted to rule out horses that maybe have like a nasopharyngeal cicatrix, upper airway things that could contribute to EIPH or be the cause of the horse's issues. Also, each horse, we did a tracheal blood score, tracheal mucus score, and measured a septum thickness score as well. And so all those got scored on every horse. We weren't scoping those horses immediately after runs. And so we were checking for bleeding and scoring it. But because of the time lapse between the run and the scopes, it wasn't going to be a great marker for success of the Shockwave. Each horse had a lung ultrasound performed. The reason I did this, and probably it didn't matter so much as we got through the study, but initially I wasn't sure if maybe those horses that were bleeding had some area of consolidation or areas where in the bleeding where maybe that Shockwave was actually getting into the lung parenchyma past that air interface, because if you had some some blood and things there that maybe you were actually penetrating that and helping the lungs heal, recover faster. And maybe that's why maybe there was some improvement from that. Also noticed those horses started noticing those horses had some pleural thickening in the caudodorsal lung. So I created a grading system for that and graded all the horses on that to see if there's some correlation there. So really, I couldn't see on ultrasound. I couldn't see a difference in the horses as far as the lung parenchyma goes. Like it was all pleura and then air interface. I couldn't see any areas that I said, oh yeah, this looks like areas of some bleeding where we could actually penetrate. There was a lot of horses had pleural thickening in that area. There was no correlation between response and pleural thickening or anything else in the study. So really didn't find much significant from the ultrasound. We did perform BALs in every horse pre and post. These were performed blind. We didn't use a scope. And then we also, from the BAL, I created a red blood cell grading system, 0 to 4. And they also got sent off for cytology to equine lung experts. My original plan was to use red blood cells per high-powered field as our marker for success. The problem was we weren't consistently getting numbers back. Like sometimes we would get a number, sometimes it would say few or many, just a broad term, which made it difficult to compare horses. And so we use this grading system also from the beginning, and that's kind of what we end up relying on. The system's pretty self-explanatory here. 0 to 4, 0 being no visible blood or clear, and 4 looking like a jug stick. So every horse, the same person graded every horse every time we pulled the blood. In the study, we only included grade 3s and 4s, so we didn't include the horses with milder bleeding. Protocol, we did 750 shocks per side, so 750 left, 750 right. We used the collodorsal lung fields on both sides. I would mark the area while I was ultrasounding and spray alcohol on those areas and kind of outline it for the person that was going to do the shockwave. We did E8 energy setting. We used the 80 millimeter trode at 480 hertz for the frequency. And we did like a vertical intercostal pattern. So just kind of slowly going up and down. Obviously, we're not hitting between the ribs every time. I'm sure we're shocking some ribs too, but we were just trying to basically get in between those ribs going up and down. We had 21 horses that completed the trial. 9 of those horses were on Lasix. 13 of those horses exhibited epistaxis during the runs. We had 20 screen fails, and so just as many screen fails as we had horses completed the trials, which is why at the end we just went to horses that had epistaxis. So we were finding a lot of horses that the owners really thought they had EIPH, and that was causing their problems, but we figured out those horses didn't have EIPH, and there was something else going on. So I think it probably gets blamed for a lot of things that are where it's not the real problem. So as far as the results go, we had 76% of the horses improve at least one grade or one red blood cell score grade. 47, so half the horses improved at least 2 scores. What was really interesting was that every single horse had a neutrophilic asthma that we looked at. And though that would be defined as neutrophils on the BAL higher than 5%. And so the lowest one we had was 7%, all the way up to 38% on the first BALs. We had 4 horses that had a concurrent mastocytosis and 2 horses that had a current eosinophilia. When we looked at all the neutrophil counts pre and post, 67% of the horses improved at least 6% or more on their neutrophils. And so we saw a really significant improvement on neutrophils in the lungs from the first test, from the first BAL to the second. All right, so this chart can be a little overwhelming, but the red C are chronic horses, and the white L is horses that were on Lasix. So chronic was just defined as a horse that had a prior episode of epistaxis when running. And so we can see here that the chronic horses didn't have as much improvement overall as our horses where that was the first time they had been known to bleed. On the left side is the red blood cell grade changes. So you can see that the first horse there changed 4 grades, so improved from a 4 to a 0. The second group there, we had 4 horses that improved 3 grades. So that'd be a 4 to a 1 or 3 to a 0. And then we also had 4 horses that improved 4 horses that improved 2 grades. That'd be from a 3 to a 1 or 4 to a 2. We had 1 outlier for a horse that decreased neutrophils. Neutrophils increased by 9%, but the horse did improve 2 grades. Then look at the bottom, and we've got our horses that only improved 1 grade, which is still improvement, but not as much as the horses that we see higher on that chart that had greater increases or greater decreases in neutrophils. And I'll also see the horses that didn't respond at all. So the 2 that didn't respond at all that had improvement in neutrophils also had really high eosinophils. And so we'll have a case kind of like this in talk, and we'll talk about why that might be with our asthma discussion. And then on the right there, you can see those horses that had a pretty significant increase in neutrophils did not improve on the bleeding scores. So I think the big takeaway from this is that, at least the big takeaway for me, was that there seems to be a very strong correlation between changes in neutrophils and improvement on EIPH, on bleeding. And so if those neutrophils started to decrease on those horses, they're more likely to improve on EIPH with having less severe bleeding. So how do we interpret the results? We didn't have any controls, so that's, that could be a problem. I don't know, and hasn't been any research on what's the normal inter-race variance for EIPH on barrel racing horses. So if a horse has a grade 4 bleed one race, how much would they normally change on the next race without being treated? I don't know that, and I couldn't find any research that showed that. Is the red blood cell scoring system valid? It seemed like a pretty reliable way for us to test it without just relying on the cytology, which we weren't just getting the numbers back to verify that that was working. So we ended up having to use the scoring system. So I would like to, it'd be nice to have a study where we did have all the red blood cells per high power field that we could compare to that scoring system to validate it. And then again, the big takeaway that I mentioned is that there is a clear trend between changes in neutrophils and improvement on EIPH. Down here at the bottom, we kind of talked about the improvements we saw. So we saw 76% improved 1 grade. We had 47% improved at least 2 grades. That's only 21 horses, so not a lot of horses. Probably the largest furosemide study that I can find had 68% of the horses that improved at least 1 grade. Now that's using the tracheal scoring system for blood. So that's those race horses that they're scoping immediately after they run and measuring improvement based on changes in those scores. So, but they had 405 horses in that study. So obviously a lot more horses than we had. So it's not exactly a apples and apples comparison, but just to give you an idea of typically what's out there as far as the percentages increases or improvements we get with furosemide. So, when we think about what we're treating and how we're treating things, always, and I'm sure you do, want to understand kind of what's going on, what mechanisms of action are going on, and so kind of dove down and look at the research that we do have on what Shockwave does do. So this study up here on the upper left corner, that was a equine model. They used pre and post blood markers before and after Shockwave therapy of the legs. What they found on that study was that interleukin-1 beta and IL-6 were significantly downregulated, while TNF alpha, IL-1RA, and TLR2 were significantly upregulated. So interleukin-1 beta and IL-6, they are both considered inflammatory cytokines. IL-1RA is considered anti-inflammatory. If you look to the right there, that's a study that was done in vitro on human macrophages. What they found on that was that Shockwave therapy can downregulate IL-33, IL-17A, and interleukin-1 beta. So those are all inflammatory cytokines. And then there was a cartilage rat model there at the bottom that showed a significant increase in IL-10, which is an anti-inflammatory cytokine, and also a reduction in interleukin-1 beta production. So overall, generally, those that showed Shockwave can decrease or downregulate inflammatory cytokines and upregulate anti-inflammatory cytokines. Now, how does that relate to the lungs? Well, we'll talk about that. So basically, with lung inflammation, equine asthma syndrome, there's 3 distinct immune pathways that typically will cause asthma. So the one on the left is Th2 pathway. That's the pathway that recruits eosinophils from the bloodstream into the lungs. And that model, if we look at the cytokines that are stimulative for that model, none of those cytokines that we know Shockwave downregulates. And so there's not really much mechanism of action that I could find that where we would have any luck with a Th2 pathway using Shockwave therapy. Here in the middle is Th17 pathway. That's generally considered the pathway that typically recruits neutrophils into the airway. You can see there IL-6 and IL-17. are major players to stimulate that pathway, and those are all cytokines that are downregulated with shockwave therapy. TH1, the TH1 pathway is considered the main pathway for degranulation of mast cells. The degranulation is the part that causes the inflammation, and IL-33 is one of the main players in that pathway, and we know that's downregulated by shockwave therapy. So we can kind of see a reason why we might be able to influence the inflammation in the lungs using shockwave therapy. Dive in a little bit deeper to the TH17 pathway. So we think about what's happened. So we have dust, we have particles enter the trachea, go down to the lungs. There's these toll-like receptors on the mucosa inside the airway that sense these particles. It then sends messages. So IL-1, IL-6, which are both downregulated by shockwave, those are messengers basically that are sent to the lymph nodes. Depending on the combination of messages, the TH17 lymph node gets activated. And so once that gets activated, then it sends more signals, IL-17 and TNF-alpha. Those signals get sent, and then those recruit neutrophils to the body. That recruits neutrophils to the airway. And so basically, we're just decreasing the messaging for inflammation using shockwave. IL-1RA and IL-10, which both are upregulated by shockwave therapy, they both downregulate the TH17 immune pathway. So there's several mechanisms here, plausible mechanisms at least, that we could be affecting with shockwave therapy. For mast cells, kind of a similar system early on. IL-33 is one of the major players in mast cell degranulation. That's downregulated by shockwave. Mast cells are kind of tricky because they release a lot of stuff when they degranulate. So they release histamines, proteases, and cytokines. That's why they're hard to treat, because it's hard to pinpoint all those things. You can put on antihistamine, you may get a little bit of help, but not much. Proteases, those can be difficult to treat. I think there may be a chance you could nebulize some orthobiologics to help with that aspect of it. And then the cytokines. In humans, in the past, it's been difficult to treat in humans. There's a very effective treatment now that's a monoclonal anti-IgE antibody. That's very effective. However, it's pretty cost prohibitive to use it in horses. So, all right. So after I looked at the results, looked at the neutrophils, kind of what was going on with that EIPH study relative to the correlation of neutrophils to the red blood cell changes, I was like, okay, it looks like we're doing something with asthma here. All these horses have asthma. We had a pretty good amount of improvement. So let's shockwave some horses with asthma and just see what happens. And so we just did a little proof of concept trial. This one wasn't very rigorous. It was just, they need to have been coughing for 2 weeks at least. The coughing had to have been consistent or worsening over 2 weeks. We did pull a SAA on these horses just to make sure they didn't have, indications of viral infection or bacterial or anything like that. Did a physical exam. So we did 2 shockwave treatments on these horses, 1 week apart. We were shocking the caudal 70% of the lungs, kind of similar. We did the same basically model we did on the EIPH study. We had 14 horses that entered this trial and completed it. 3 were severe, so we did 3 horses with feves, and 11 were moderate asthma horses that were basically coughing. What we saw was there was no lasting improvement on the severe asthma cases. Some of those did reportedly have some improvement in coughing and a few symptomatic things that improved for short term, but it didn't improve the effort they were having to take to breathe. So that really wasn't that significant. Of the 11 horses that were the mild to moderate cases, 4 of 11 of those were improved anywhere from 0 to 30%. And we had 7 of 11 that improved at least 60%. So we thought that was fairly significant. Even the horses that improve 50%, the clients are pretty happy because oftentimes that's the difference in being able to ride the horse and not ride the horse because of how it's coughing. So based on that, we decided to put a little bit more diagnostics into another trial. And so we didn't use the same horses. We had a different set of horses. And so for that trial, those horses had to have a consistent cough or worsening cough for at least 2 weeks. All the horses that we saw presented for coughing when exercise. So here's all horses that are in work. Most of them were competing in jumping, barrel racing, roping, different sports. We had a 14-day washout period for any corticosteroids or any medications to treat asthma. We did not allow horses with severe asthma to be admitted to the study. The environment, the feed, the hay had to stay the same for the trial. So we had a couple of horses that were on round bills, and we told them they had to stay on the round bills while they were going through the study. Also, the horses had to continue in regular work because we needed the feedback as far as how they're improving, because clinically, these horses would seem normal. They come in, we'd listen to them. You might hear a little tracheal rattle, maybe some just increased sounds, but from a physical exam standpoint, these horses were pretty normal and weren't coughing when we were seeing them. From a diagnostic standpoint, we performed endoscopies and VELs on day 1 in week 4. And then we also did a CBC on day 1 just to rule out horses that may have infectious causes for the symptoms. We did a VAS clinical score. So that was the scoring system that I used when I was doing the physical exams on the horses. And then we also did a VAS client score. And so weekly, the client was doing a scoring system at home, which we'll talk about. We did 2 Shockwave treatments that were 2 weeks apart on both lung fields. For this one, we did more of the entire lung field. We just avoided the heart, but we tried to cover as much of the lung field as we could. So we did a higher dose in a larger area for this study than the previous. And our main outcome parameter was improvement in cough, because we felt like that was going to be the most objective way to tell if these horses are improving. So this study is still ongoing. We're still enrolling horses. To date, we have 21 horses that have completed. We have several horses, we have some horses now that are enrolled. So what we saw after 2 weeks, so we treated the horses, had them come back 2 weeks later, and we did a second treatment at that point. But by the time they came back in, we had 5 horses that hadn't improved at all, so 5 of 21. We had 10 horses that had improved around 50%. And then we had 6 horses that had improved 100%. So 2 weeks they had completely stopped coughing at work. We're asymptomatic. And these percentages are based on the client's scoring of coughing during exercise. So that's what we're using as our marker here. So we shockwave the horses again, had them come back two weeks after that. So at the 4-week mark, after 2 treatments, we had 1 horse that had not improved. We had 3 horses that had improved around 50%. We had 2 horses that had improved 75%. And 15 of 21 horses had improved 90 to 100%. So there was a big jump from week 2 to week 4 in improvement in coughing during exercise. We did a tracheal mucus score, and the scoring system for looking at tracheal mucus has been shown to be effective as a marker for equine asthma syndrome. So it correlates with mainly correlates with neutrophilic inflammation on BAL. It does not correlate really with mast cell inflammation, but it does with neutrophils. So we felt like that was an important marker to see if we're getting improvement on. What we found on that was we had no horses that had an increase in mucus. We had 5 horses that just had no change. So if they were a grade 2, they were grade 2, at both checks. We had 7 of the 21 horses. So a third of the horses had 1 grade improvement. And we had 9 of 21 horses have a 2+ grade improvement. So we thought that was fairly significant that we were seeing that much improvement on the mucus in those horses on scope. And I hadn't correlated this when we were going through the study. I didn't even realize this until I sat down preparing this talk and started looking at the data that we had that much improvement. All right, to go over the VAS score, the scoring system has been shown to be more effective. The client scoring system has been shown to be more effective at ascertaining improvement on asthma versus just the clinical scoring system that we were doing, for the reasons that I mentioned, is that the horses look pretty normal when we see them. So we looked at 4 different categories that the owners were scoring. They all got scored from a 0 to 100, with 100 being the most severe. We looked at respiratory effort, cough at rest, cough during exercise, and nasal drainage. And then we totaled those scores pre-treatment, and then weeks 1 through 4. So if we look here at the VAS results, so there's a max 400 score. So if you had the worst horse, that had the max on every symptom, it would be scored 400. So starting scores range from 60 to 300, and then Indy scores range from 0 to 200. And so we had obviously an improvement in the total scores. And then if you look at percentages over here on the right, I didn't want the data to get skewed if horses that we were treating in the fall were getting better because of seasonal changes. Like maybe these horses are going to get better anyway, because a lot of them do in the fall, wintertime. So I normalized the percentages for the months, where I kind of categorized it into summer, fall, and spring. And you can see there's really no change. So 72% of the horses in the summer improved, 68.5%, or not improved, but improved 72% on their VAS scores. In the fall, they improved 68.5%. In the spring, they improved almost 70%. And then overall for the entire study, we had a 66.7% overall average improvement on the VAS score. VAL findings. This was quite different from the EIPH study. Really, there wasn't a trend like we saw in the EIPH as far as improvement in or changes in neutrophils and changes in clinical response, which that's actually consistent with what a lot of other asthma studies have found, especially if you're doing VALs about a month apart. Just want to rely on the VAS scores to really see if those horses were getting better. We found the horses that had mastocytosis. So we had a couple that had a primary mastocytosis or mast cell-driven asthma. Those horses, we saw a 50 to 90% response. In response just means coughing during exercise. That's what we're using for that marker. The one non-responder we had, that horse had 14.5% eosinophils. So greater than 2% is abnormal. And this is almost really identical to the EIPH study, where we had the non-responding horses that had really high eosinophils. And then in this study also, the one horse that didn't respond had really high eosinophils. Just as a note, I put that horse on some oral pred for a couple of weeks, and it completely resolved the symptoms of the horse. And so because of the pathway that the eosinophils, the immune pathway that recruits eosinophils, we just don't have any effect on that pathway. And so those horses just aren't going to respond to this therapy. But they do usually respond very well to corticosteroids. Pred, Dex, Equihaler, all those things would probably be effective. When we look at our two trials, we had a lot better results with the full trial than the proof of concept trial. I mean, one reason could be that we just didn't do as many diagnostics on the first one. And maybe some of those horses didn't have asthma. Maybe they had something else going on. We just didn't know it because we didn't scope them. We didn't do VALs. Now, the second trial, we did a larger dose. So, there's 1,000 more shocks per side. On the second trial, the treatment interval was different. So in the first trial, it was 1 week. Second trial, it was 2 weeks apart. We also did more of the entire lung field. And again, these improvements at the bottom are based on the client scoring of cough during exercise. And you can see there's a profound difference in the horses that improved, that were up in that upper range, that 190 to 100% range. We only had 2 of 11 in the first study. That time we had 15 to 21 in the full study. So it's pretty significant difference in response there. And similar times of year too. So we did the first trial was summer into early fall, and the second trial started the next summer and went into the fall. So similar times of year. Where do we go from here? Like, what else could we do to try to parse this out a little bit more? Well, one thing we're looking at doing is cytokine testing of the BAL fluid and peripheral blood. So we're saving and freezing samples of BAL fluid and peripheral blood pre and post. And so we're planning on testing the cytokines in that to look for changes there. Kind of figuring out response length. I think it's going to vary. So we had 2 barrel horses these are barrel horses just running every weekend, have fairly significant moderate asthma. Those horses improved for about 1 month after the treatment protocol was done. We did end up nebulizing those horses with some orthobiologics, and that has seemed to work well for those horses. So we kind of maintained them with that. The other horses that we've had symptoms return on, no. We've had 2 that their symptoms returned 6 months later. So we shockwaved the horses. They weren't treated for anything after that for asthma. And then 6 months later, they coughed again. We treated them again. and then it resolved it again. So I think it's going to be variable. We've had plenty of horses where the symptoms have never returned. So it's kind of all over the place as far as length of efficacy. But if you can get 6 months out of it, it's great. Obviously you'd like to get greater than 1 month. But what I've started doing on a lot of these horses, these barrel racing horses that are just running constantly inhaling dust, is I shockwave them 2 times, and also start them on nebulization of orthobiologics at that point too, and then maintain them on that. And then we'll periodically come back and shockwave their lungs, and that seems to work well. Obviously, we could refine the protocol. So, we haven't played around with it a lot because we've had to stick with doing a study. You kind of have to stick with the same protocol. And so there may be things that work better that we're not doing, but we can figure those out over time. So the take-home message here, with EIPH, we saw 76% improvement, 1 grade, at least 1 grade on VL fluid RBC score. On the asthma, we saw 75% or 76% improved after 1 treatment. So that's kind of interesting that we had the exact same percentage increase from 1 treatment, because the EIPH, we're just doing 1 treatment. And so that was pretty interesting. Those kind of matched. And then with the asthma, we saw a 95% success rate after 2 treatments. And so that success rate just means they improved it all. The moderate equine asthma, we had 71% that improved 90 to 100% on client cough score, 67% average improvement on VAS clinical score, and then 43% that improved at least 2 grades on tracheal mucus score. So I thought altogether this was pretty significant as far as improvement on these horses with mild to moderate asthma. Again, eosinophilic asthma doesn't seem to respond at all. Is there a dose-dependent effect? I think there may be. Obviously, there was much better results in the second trial. That could be for a lot of reasons, but we did put more shocks in those horses, so that may be a big factor there. We did see a marked improvement after the second treatment, so I do think the second treatment's important. Like I said, a lot of them did improve after the first, but we really saw the big difference after we shocked them the second time. And there's no lasting improvements, no evidence that we could see for severe asthma cases. We only did 3 horses, so maybe we should do more. But we elected not to continue treating the severe asthma horses based on lack of response in the first 3 that we did. All right, do we have any questions?